Good evening. Welcome to the forum at the Kennedy School of Government, where our topic tonight is Your Money or Your Life, another in our series of forums on issues in healthcare reform. We have a bit of a sleight of hand trick tonight. It looks like we're going to have 3 speakers, but in fact we have 4 speakers. Our speakers are Mark Roberts, Hale Champion, Steve Roberts, and Nancy Johnson. Nancy, can you hear us? Nancy,
I can hear you fine.
Okay. Nancy, you're in Washington, is that correct?
Correct. I'm in my office in the Cannon Building in Washington. We voted this afternoon, and we'll be voting again tomorrow morning.
Okay, so Nancy stayed in Washington to vote, and I will introduce her with more details later, but she will be able to hear us as long as we speak into the microphone, and as long as those of you later asking questions speak into the microphone, and she will give us her remarks later. Many of you were expecting yet another person to be on the panel, and that is Cokie Roberts. Cokie couldn't make it, and as many of us know, it takes 2 good men to replace 1 woman. So we have Mark and Steve instead, who I will introduce later. Over the past several years, the crescendo of concern about our health care situation has increased dramatically, and we've heard a great deal of talk about access to health care, how to increase it, how to maintain or increase the quality of care that people receive, and how to maintain or reduce costs, or at least reduce the increase in the rise in costs. The question before us now is, can we possibly address all 3 of these issues? Can we reform our health care system? And in doing so, will we forget the bottom line, which is the health and the well-being of the American public? Tonight we're going to address this again, another in the series of forums that's brought to you by the Institute of Politics and the Malcolm Weiner Center for Social Policy. I'm Julie Wilson, the director of the Malcolm Weiner Center, and I'm going to introduce the 4 speakers and then moderate the questions. Our first speaker is Mark Roberts, who is a professor at the School of Public Health and the Kennedy School of Government. He's a graduate of Harvard College and has a PhD in economics from Harvard. He has been primarily an academic since graduating from Harvard, although he's done a great deal of consulting to a variety of states and agencies. He's currently the faculty chair at the Kennedy School of the State and Local Government Executive Program and was formerly the head of executive education at the School of Public Health. So that Mark's teaching has taken him both in the traditional classroom and in classrooms that are filled primarily with people who have to act on the policies and manage the policies that Mark proclaims in his books. Mark is the author or co-author of 4 books in addition to the book that is featured tonight, Your Money or Your Life. You can get a copy over here. And he's also the author of more than 40 articles. Mark.
Thank you, Julie. It's a great pleasure to be here tonight and to talk yet again about the healthcare crisis. The industry of talking about the healthcare crisis has not yet grown to the point where it's as great as the healthcare industry itself, but it threatens to become so. What we thought we would do tonight in terms of allocating different roles, I will talk a little bit about both how we have gotten to where we are and how we should think about various criteria for understanding alternative healthcare reform plans. Hale will talk a little bit about the history, and as Julie introduces him, you'll see that Hale has lived a great deal of the history. Nancy Johnson will talk about it from a congressional perspective, and Steve will finish up with some thoughts about the politics and where the whole thing is likely to go. For those of you who think that Steve and I look a lot alike, the truth is that we are actually twin brothers. And so the family resemblance you think you perceive is accurately done so. Before I actually launch into the substance of what I want to say, I want to acknowledge that the book whose publication date is today was produced jointly by myself and a woman named Alexandra Clyde, who I promised I would not introduce. Alex is a former student and now collaborator and colleague, and for those of you who are in the academy, you know that one of the really great privileges about being an academic is the chance to have people move from being your students to being your teachers, and a great deal of the words and the ideas and the arguments in the book are due to Alex, and I'm really grateful for her to her for the role that she played in producing this in about 7 weeks this summer. People said, how could you write a book in 7 weeks? Well, in some sense, we've been working on it for 10 years, and so it only takes 7 weeks to actually write. I want to say three main things about where we are with regard to the healthcare system. First, to underscore that the current system really is not performing very well. We have costs that are between 60% and 100% higher than every other industrial country in the world, and this is serious business. We're at $900 a car more than the Japanese, and this has a serious effect on our international competitive performance. Healthcare costs are now the single largest component of state budgets all across the country and rising rapidly. A major cause of deficits at the state level and the federal level. Indeed, in some ways, Bill Clinton's whole economic reform plan is hostage to his ability to control Medicare and Medicaid costs. Secondly, in light of these very high costs, we do not have particularly good life expectancy. You hear over and over again how terrific the U.S. healthcare system is and how we have the greatest healthcare system in the world, but the fact of the matter is most European countries have life expectancy between 3 and 5 years longer than ours. And that's a big difference, since if we cured cancer entirely, it would only add about 2 or 2.5 years to our national life expectancy. So the fact is the Germans do better than we would do even if we cured cancer. And their citizens have roughly twice as many visits per year to physicians. They have more hospital admissions. They cover more things. And yet we're spending 14% of our gross domestic product, and they're spending 8%. And the percentage we're spending is rising rapidly, and the percentage they're spending is falling. Clearly, something is really quite profoundly wrong with the American healthcare system. In addition, the American system is full of levels of inefficiency and duplication and waste that are really quite astonishing when you get to look at it in some detail. America has the most expensive and newest hospital infrastructure. Here in Boston, our average hospital bed is 7 years old. In most of Europe, an average hospital bed is 25 or 30 years old. A teaching hospital in the United States has 6 to 7 full-time equivalent employees for every occupied bed. A Canadian hospital has 4. A German or a Japanese hospital has 2. Indeed, an American teaching hospital has more administrative people per bed than a European hospital has total employees per bed. Now, what are the causes of this situation? And I want to quickly the first rule of public speaking is you should never have a list with more than 3 items in it. Unfortunately, I have a list with 8 items in it because the situation is sufficiently complicated that it's a moderately long list. First is healthcare technology. The incentive system in the United States is such that the wonderfully productive and efficient and smart group of people producing new medical technology primarily produce technology that increases costs as opposed to save costs, because all the incentives are there to do things that nobody could do before, no matter how high the cost. If you drive by the medical school late at night, you'll see the lights are on in all the windows of the labs. And what are those smart kids doing there at 11 o'clock at night on a cold, rainy Thursday? They are inventing new ways to spend healthcare dollars. And will they find them? The answer is yes. My money's on them. Indeed, your money's on them. The second part of the current system that's worth noting is the politics of healthcare. If you think the military-industrial complex is hard to reform, the medical-industrial complex is a lot tougher. It's a lot bigger. We couldn't close the Groton, Connecticut shipyards where the Seawolf sub is built to save 8,000 jobs. And President Clinton certainly is not about to close down the health insurance industry in Hartford, Connecticut, where there are 28,000 jobs. Indeed, in some ways, the president's plan is an elaborate make-work policy for the health insurance industry, and there's a certain irony that they, of all people, have chosen to attack him, when basically what he's been trying to do is save them from themselves. The third important piece is the sociology of it. America is the only society that likes to believe that death is optional, at least for individuals eligible for American passports. And we spend a great deal of time and money on individuals who really are, from any point of view, not going to benefit very greatly from the resources that we expend. And we do so in a way that reflects a certain national enthusiasm for technology. And the defenders of this system say, well, if it was your mother, certainly you would want everything to be done. And I would say yes, particularly if somebody else is going to pay for it, because we've constructed a system in which our anxiety is not disciplined by any consciousness of the fiscal realities. Then there's what's happening to the pattern of disease. It's really worth noting that Americans now die of chronic and developmental disease. With the very troublesome and important exception of AIDS, Americans no longer die from infectious disease. And what this means is that health care costs are now highly predictable. We know who's going to be sick next year. The answer is people who are already sick. And what that means is that in many ways the health insurance market, which is based on protecting people against unpredictable risks, is becoming increasingly inappropriate as a way of trying to deal with the problem of healthcare financing. Because the only way we can deal with health insurance markets is by denying the available information about who is sick. The best way to make money in the health insurance business, after all, is to make sure all the sick people join somebody else's insurance plan. And indeed, this task known as risk selection is widely practiced in the insurance industry. The story is widely told among health policy people of the California Health Maintenance Organization that had its open enrollment offices on the 3rd floor of buildings without elevators. They would take anybody who could walk up 2 flights. We could talk about, there are also systematic scientific studies that prove this. Now, the next point is one that those of us who are economists outside the system were not told by physicians early on. It's sort of the hidden secret of medicine, and that is very often doctors have no idea what to do. And the consequence of this clinical ambiguity, the fact that really a great deal of medical practice is sort of medieval folk wisdom updated. The consequence of this needs to be understood in the context of how we pay doctors. We pay doctors and hospitals, by and large, in exactly the same way we pay exploited immigrant women in sweatshops in Chinatown in New York City. That is on a piecework basis. Now imagine what happens. We pay people on a piecework basis, and very often they don't know what to do. Well, their incentives are not neutral in this system. We pay them more to do more. We have all these people busy thinking new things for them to do all the time. We have institutions that are protected by a strong political system to create the capacity to do things, enormous social anxiety which tells us we want them to do new things, and then we're surprised that healthcare costs continue to grow. When you think of the structural incentives we've built into the system, there are times I'm surprised it's at only 14% of the gross domestic product. And even Mrs. Clinton's optimistic estimates that under her plan it will only grow to 17% instead of 20% by the end of the millennium gives you a sense about just how strong the underlying cost increasing forces are. Finally, we finance healthcare in this country primarily with insurance premiums. Now, if you think about it from a public finance point of view, an insurance premium is like a head tax. Everybody pays the same regardless of income. This is an extraordinarily regressive and unfair way to finance public services. Indeed, when Margaret Thatcher proposed a head tax to finance local government services in the UK, the Conservative Party in England threw her out as overly mean-spirited. Yet this is exactly the way we finance the bulk of healthcare services in the United States, with very little of an ability to pay principal. Now, what are our options for dealing with the problem? There are basically 2 ways we can go. One way, which the title of the book suggests, Your Money or Your Life, is to try to improve the healthcare system by having people shop for care, having them make the money or your life trade-off. And what's interesting about both the Clinton plan and the Republican alternatives, which I'm sure Congresswoman Johnson will discuss, is that they're all based on increasing the amount of shopping. They're all designed to say, well, you can spend more and get more, or spend less and get less. There are 2 problems with a basic shopping approach. One, it confronts people with very difficult dilemmas about how much to spend and how much to get. Secondly, it will require, as I think we'll see in the course of the evening, drastic reorganizations of the delivery system. The alternative would be to operate not on the demand side, but on the supply side, to limit the amount of money we spend, to tell everybody in the delivery system, hey, look, you guys, next year you get $875 billion, not a penny more, live within your means. And try to find some way to enlist the delivery system as our aids in allocating the limited resources effectively. For better or worse, that option does not seem to be on the table in the United States at the moment, although I personally regret doing so. To conclude, I think we need to think about the question of how we will know whether or not we have a good health care reform. What emerges from this process? First, I would suggest to you is will the program really be universal? Will everybody be in? If the program is not universal, there'll be an enormous incentive for everybody to save money by excluding from the system high-cost patients. And since the poor tend to be sick and the sick tend to be poor, a non-universal system will place an enormous burden on the old and the sick. And the only way any one of us can be sure that the care will be there when we need it is in a genuinely universal system, because we may be young and healthy today, but we will be old and sick tomorrow. And the only sure protection for any of us, it seems to me, is a universal system. Secondly, will there be effective cost controls? The providers will fight mightily against effective cost controls, because remember, every healthcare cost is someone's healthcare income. Healthcare cost containment is healthcare income limitation. And it will be impossible to limit costs without limiting incomes, and those people can be expected to be in there slugging at every step of the way. Without effective cost controls, we will not be able to afford universality. And if we go to a system where we promise phased-in universality without cost controls, my fear is that when it turns out that universality has a high price without cost controls, instead of imposing cost controls, we'll pull back on universality. And that's exactly, of course, what's happened so far in Massachusetts, where we've delayed over and over again the promise of universal coverage. And in that sense, Massachusetts may lead the nation. Third, there's the question of the equity with which we finance the system. We cannot have a universal system unless we have ability to pay-based financing, because the poor simply cannot afford to pay for their own care. And the only way to have a universal system is to have an important element of redistribution within it. Three other criteria that are worth thinking about are how equitable the access to care is. Access to care is now very inequitable. We know that the poor make much less use of high-tech services than the rich. How much choice people will have about their own providers. And finally, how much we will do about prevention. One of the peculiarities of a system based on political influence is that the powerful teaching hospitals and the well-entrenched provider interests have been able to push the resource allocation pattern in a way such that money that could be very well spent from a cost-effective point of view in preventing disease is now largely spent in much less effective ways in curing disease. I think that almost all the real opportunities for improving the health status of the country are, in fact, in preventative services, because after all, the three things that Americans die of, cardiovascular disease, number 1, cancer, number 2, and trauma, number 3, which together are 75% of all mortality, all are conditions with a high degree of behavioral cause and prevention as a potential leverage point. It will, in some ways, in closing, the one thing about the President's proposal that I regret most, and I think he's to be congratulated for trying to do the impossible, because he's in some ways set himself an impossible task, which is to make everybody better off, to provide care for everybody without increasing anybody's costs. And you know that that task is not possible to do. But he's tried, and to be congratulated for trying. The one real regret I have is I think he's posed the issue in the wrong way by saying that he would make everybody better off. He's turned the Congress and the consideration of health care into the analogy of a grand Kmart. Right? Everybody's going to go to Congress and will shop for the best bargain for themselves in the plan. Everybody's going to go and say, what's in it for me? Is the plan going to make me better off? And in some ways, health insurance, I would say, is one of the defining characteristics of the society as a whole. I urge on you that as we go forward with this, to think about the question, not only will you be better off, that's a legitimate concern, but will the society be better off? Not only is this good for you, but is this good for the country? Because in some sense, the country will be defined by the way in which we meet the challenge of reforming the healthcare system. Thank you very much.
Thank you, Mark. Our next speaker is Hale Champion, who's a fun person to introduce because Hale has done so many things that each time you introduce him, you can make it sound like he's had a very different career than the last time. So after I tell you this, Hale will stand up and tell you that he actually has never really had a career in health, but it's going to sound very different now. Hale began with a degree in English and was a journalist for about a decade, taking his first public sector job as the assistant to Representative Andrew J.B. Miller, who was the floor manager for Truman's healthcare reform plan. He next came into the healthcare arena in the early 60s when he worked for Governor Pat Brown, where he was involved in getting Medi-Cal passed in California. This was just before President Johnson began promoting Medicaid and Medicare. Later, he was Undersecretary for then Health, Education, and Welfare in the Carter administration, where he headed the National Health Reform Commission and drafted the Carter Health Care Reform Plan. More recently, he was Chief of Staff for Governor Michael Dukakis of Massachusetts, where he put together the Health Care Reform Plan and represented the governor while the governor was campaigning for president. Recently, he's been chair of the board of the Kaiser Family Foundation, which has invested an enormous amount in research and polling on the issues of healthcare reform with the goal of getting the government functioning better in the healthcare reform arena. So Hale, Hale's going to tell us a little bit about the history, what we've learned, and what the difficulties are. I should add that Hale has also been on the faculty of the Kennedy School and is an emeritus faculty member now.
I really only have two feeble excuses for being here. The first is they needed somebody not named Roberts to plug Mark's book, which I'm more than happy to do. One of the nicest things about this is I was able to read it over the lunch hour. You can say that for almost no other book on this subject. And it is, as a matter of fact, it's a remarkably trenchant and lays out the problems very well. I could tell that Mark had a collaborator on it, however, because it was seemly. It was circumspect almost in the way in which it dealt with many of these problems. But fortunately, you didn't live through that censor tonight, so you got the full Mark Roberts. Well, not all, but and I hope there will be more later on, because he really does bring an unusually well-informed and useful, I think, viewpoint to this discussion. My other excuse for being here is, I'm a sort of a Dickensian ghost of health reform past. Down in the dungeons and off in the tunnels of the past, all of the failures of health reform of one kind or another, the banshees and the ghosts echoing about things that didn't happen when they should have happened. And listening to Mark, I think I was struck by the fact that while he's talking about what we see now as a set of relatively recent events leading where the problem is really not a lot different than it was when I worked in the Congress almost 50 years ago. It's a lot bigger, and it's a lot more expensive, and it's a lot more complicated. But the fundamental problems, the fundamental things that were wrong then are still at the root of what's wrong today. It's just gotten enormously larger, and size does change character, and in that regard, we've got a lot bigger and more difficult problem than we had before. But it's only because of the change of size, I think, not fundamentally the attitudes that made it difficult to get people to pay attention then are most of the attitudes that we have now. And what I thought I might do in just a few minutes is not try to do a whole history, but to try to draw a few lessons out of failures past. There's not a lot to say about the failure of the Truman National Health Plan, except maybe that it was a classic case. That was the old Wagner-Murray-Dingle bill of putting policy over politics. And I want to come back to that subject a little bit, because I think the president here knows perfectly well that he's put politics over policy, and I say thank God for it. We probably wouldn't be at this stage of the discussion with a chance of doing some of the kinds of things we may be able to do if he hadn't made that very hard decision. I basically agree with Mark as to what is the right policy solution and framework here, but I don't know anybody who really thinks carefully about it, who thinks we could have gotten to this present stage of the discussion and even the sort of consensus we now have where everybody says we have to deal with this problem if they had before them an extreme, in their view, an extreme way of reform that a lot of people, not me, would regard as revolutionary. That somehow the politics of this has to be incremental, and though policy, I think, would dictate that you get a lot more drastic, that if you tried to, you'd lose this opportunity. So there really have been only two presidents who've put this thing out in front in the whole 50 years. Lyndon Johnson, who was the only one who up to now has gotten anything, and he got it by putting politics way ahead of policy. Basically, he said, if you'll let me do this, I'll open the federal treasury, and you can come and take out of it what you will. It was a terrible policy decision, but it's the only reason we have Medicare and Medicaid today. We're paying a lot of the prices for it, but it's how we got it. I think Clinton has shown some more respect for policy than that. I think he would have, the evidence is there, 1,300 and some pages of it, that he's taken up detail that nobody in the past, you know, past plans in this area look like back of the envelope compared to what we've got in front of us now in terms of dealing with policy. There's an old, people who worked in the Johnson administration all have the same story on it, but it's something to remember when you start putting together one of these things. He would always call the people who were working on it in and say, now, I'm the politician here. I'm going to worry about the politics. Don't you worry about the politics. You just tell me what's the best thing to do and the best way to do it. And these groups would go off, and every once in a while some member, me occasionally included, would say, you know, you just can't sell that. I mean, you've got to pull back a little bit. The president told us that he didn't want us to worry about the politics. He was going to take care of the politics of this situation. And so we're going to tell him what we really think is right and not worry about it. And then you'd take the thing in and you'd have the final exit meeting with Johnson. And he'd take one look at this and he said, what the hell kind of world do you people live in? Don't you know what happens when this goes to the hill? Well, that's the problem with Johnson was he didn't want to win, you know, 280 to 260. He wanted to win 508 to 1. And so he maybe gave more than was needed. He didn't pay enough attention to policy while subordinating. I think Clinton is trying to pay as much attention to it as he thinks he can. The next case history, and I say this for people who want to see this thing succeed in the best possible form, is the Carter effort. Carter and Kennedy both had plans. Neither of them would get together on them. And nothing was going to happen in that period of time as long as they didn't. And I think there's a real problem here unless the people who basically want to get to the bottom lines, the kind of interdependent necessary bottom lines, which are one, universal access, and two, cost containment, and the two are totally interdependent. You cannot redo this system reasonably and take money out of it or shift it around very well until you get a universal system. And you need to do it sooner rather than later, not stretch it out. Every time anybody mentions the Dukakis effort, I think of it as sort of the leading experiment we've got in Massachusetts in cryogenics. We passed it in 1988, and hardly anything has happened as a result. And whether it'll still be there when we go to unfreeze it or not, I don't know. But the point, I think, of that time and that period and that discussion, and by the way, most of the things, the figures that Mark used, were projections that were known at that time. We argued, Kennedy put them out, Carter put them out, where we are in terms of percentage of GNP spent on health, where we are in federal expense, what would happen to Medicaid. All of those things were perfectly predictable, and I'm talking now about 1976, 77. They not only were predictable, they were predicted, and nothing happened. So it isn't as if this is a whole new world, things have suddenly changed. This thing just keeps accelerating. But the important lesson to be drawn, I think, out of that experiment is that the people who genuinely recognize that problem and know something needs to be done about it really have to be pretty tolerant, one of the other, in sort of working through something that deals with that plan. I think the President has been quite foresightful in saying, keep remembering what we have and comparing what's emerging to what we already have. That's the important comparison, not this plan against that plan, not this beginning against that beginning, but what do we get, what do we have now, and is what we produce better than what we have now? We can continue to make a lot of improvements over the years. The third thing that I would draw from prior experiences in this field is don't try to settle everything at the federal level in this one discussion. Every one of the major interest groups wants to get this thing resolved in Washington. They did then, and they do now. They do now even more than they did then, because the federal congressional lobbying interaction has become ever more intense. As a matter of fact, most of what's been done in health in this country has been done with committees sitting with all of the interest groups represented and bargaining out agreements among them in Washington, down to almost the last detail. And everybody wants to walk, every one of those interest groups wants to walk out of Washington with a decision that this is what they want to be guaranteed in order to go along with this. Actually, a lot of these things don't have to be decided at that level. So macro policy has to be decided. What should the benefits package be? What is the national component of financing? Some things of that kind. But they don't have to decide that every state has the same managed competition system. They don't have to decide that whether a state should have a single payer system or not. There are lots of ways for the states to try different things in different ways that suit their situation. Most of the pressure, except from the governors, will come from people who want to get it all settled in Washington. And I think a lot of the things that are in those 1,342 pages could very easily flow back out if the Congress could be led to let go, to agree that they don't have to decide some of these things. Up until now, practically all the federal plans have assumed something that is all federal, all-encompassing national policy. Given the links to special populations and special problems that are in the health bill, I'm not sure that's a wise thing to continue. And one thing that ought to be looked at as we go through this process is whether all those decisions have to be made at one time. Makes job of passage immensely more difficult. You've got to keep some fundamental federal principles, rights and equity in the bill, but you don't have to tell every state how to do this. And as a matter of fact, we might learn a lot from having some of them do it differently. I think I'll close with just one other set of observations from the history. That in addition to letting some of those decisions go out away from the federal government to try different things, clearly the thing that people don't yet understand, and they're going to have to understand, and this is something that maybe Steve will get to, is the nature of the assaults that will come on this, that have come on it, will continue to come on it, the kind of concentrated ability to buy the attention of and disturb the American people without any sense of the whole. And I know it's a problem for everybody who works in the media to try to keep a sense of the whole there when they are dealing with particular parts of anything that is as big and difficult as this. But they'll try to do the best they can. What that won't deal with, of course, are the concentrated efforts to force the administration through ad campaigns and others, as the health insurance industry has done in the last 2 or 3 weeks. They've actually gotten some pieces of the plan changed in response to several $1 million worth of advertising on a given subject. And the only people who have the money or the investment to make in this are the people who will profit from those changes. And there isn't anybody else out there to do the same job on behalf of the public as a whole, or at least seen as having a relatively objective or independent kind of stand. And this has come to be an increasing problem in our national politics as that plays a role, and we haven't yet developed a way to prevent the whole debate from being drowned in misinformation and disinformation and carefully slanted kinds of materials to influence people's concerns and fears. I think the only thing you can do during this debate is just to keep reminding people that all that you really want out of all of this for the American people is what the American people already do for Congress. You need some comparable, easy to understand concepts as to what some of the Republicans, for instance, who are the most upset about all this, are already living with and not complaining about at all. That there need to be, and will continue to be, some sense of people getting involved to balance it. And the people who have the greatest interest in doing that now, unfortunately, are people who are still invested in getting what they want out of the bill. That goes back to what Mark said. Those are right things for people to want in terms of benefits and other things. But as long as they keep putting all their energies into getting what they want out of the bill, there isn't going to be the energy there to get a total package. And I guess that's the other experience here, is that it isn't just political supporters of one plan or another who are a problem in trying to get a consensus and get an ultimate product. It's the problem of everybody in the society who wants this or that and is unwilling to surrender some part of their position in order to get a reasonable and affordable package. Thank you.
Thank you, Hale. Our next speaker is Nancy Johnson, who will be phoning in from the Cannon House office building. Nancy is a Republican Congresswoman from the 6th District of Connecticut. She's been a member of Congress since 1983. She began her career with local community organizing, became a member of the Connecticut State Senate, and then moved on to Congress. You may remember Nancy as one of the people who gave the Republican responses to President Clinton's initial health care reform speech. She is currently the Deputy Minority Whip and a member of the Ways and Means Committee, which is going to play a major role in the health care reform package. She's also a member of the Republican Leadership Task Force on Health Care. Nancy.
Thank you. It's very nice to be with you. I'm sorry that I can't see the audience and be there with the other speakers, but I've enjoyed listening to them. And I agree absolutely that our health care crisis is due to rising costs. And I think it's really important to set that foundation as we move into this subject. because it's only when costs began to bleed government dry, literally. It's only when costs threatened to make American businesses non-competitive in the international market. It's only when costs began to compromise access for middle-class people and radically reduce access for poor people that health care became a major issue on Washington's agenda. Rising costs, in turn, are the consequence not primarily of paperwork, fraud and abuse, or any of those kinds of things, although, of course, they are a factor. But rising costs are primarily the consequence of our increased ability to diagnose and treat illness. And if we don't keep that in the front of our minds as we solve our health care problems, then I think we run a very great risk of making the cure worse than the disease. And as bad as the disease is, the cure, in fact, could be worse. I want to just talk a little bit about where the solutions are in Washington. What are we talking about, and what are the major controversies amongst the members, reflecting both administration plans, bipartisan plans, Democrat proposals, Republican proposals. But rather than looking at any one group of those proposals, I'd like to sort of lay out some of the solutions, and particularly first, those things about which there is a fair amount of agreement. On the issue of cost control, there are several things that we know we must do that will affect costs. First, we must reform the rules by which the insurance industry provides health care coverage to Americans. We have to determine a national basic benefit plan or average benefit plan. All parties agree on that. The Congress and the administration agrees that there must be a benefit plan that is commonly offered to all Americans. And that will, in the course of defining that, automatically deal with some of the most serious personal security issues that are a big part of this debate. For example, reforming insurance means changing the rules so that no one can be excluded for pre-existing conditions, so that no small company or no individual can have their health care premiums increased radically because they actually sought to collect from their health insurance. A lot of the personal security issues, most of the personal security issues, will be addressed by reforming the rules by which the insuring industry functions, and at the same time by providing the basic benefit program across the nation and by encouraging collective purchasing for small companies and for individuals. We know we can drive the cost of insurance down, and we're seeing this approach piloted in some of the states, and we see indeed it does reduce costs quite significantly and also increase access. But there is another thing that insurance reform does that hasn't been well understood, and it's because insurance reform has to be done at the national level for there to be a really big bang for that reform's buck, so to speak. Once the rules are changed nationwide, once an insurance company can no longer make money by selecting risk, there will be only one way insurers can profit, and that will be to assure that their people stay well longer, that they receive better preventive care, that they are helped to recover rapidly, and that they indeed are brought into the issue of their own health and wellness effectively. In other words, insurance reform will have the effect on the system of forcing the major actors in health to focus far more aggressively on wellness and prevention. And that's going to have enormous consequences for our society. Now, insurance reform has to be coupled with malpractice reform. And increasingly, there is broad agreement that malpractice reform is necessary if you want to eliminate duplicate testing, if you want to eliminate unnecessary procedures, and so on and so forth, although there is considerable disagreement as to exactly what malpractice reform ought to mean. And then there is, in addition, a good deal of agreement that that you need some further pressure on costs, whether it's the administration's global budgets and premium controls, or whether it's the bipartisan initiatives fostering of tax equity through limiting tax deductibility, or whether it's the Republicans' proposal to give everyone the opportunity for a MedSave account. There is a general agreement that there must be some other factor here to force greater cost consciousness, both among purchasers and deliverers of care. As to the access issue, there are a number of approaches that I think have broad support. I've been a strong advocate of expansion of the community health center system, as have many of my colleagues on both sides of the aisle, because if you don't fund a public infrastructure in our cities, in many rural areas, then you can say all you want about access, but you won't have it. So the reality of access requires that we better fund and expand our community health centers, that we provide vouchers so that everyone can afford insurance. And no matter how much we drive the cost down, there will still be an affordability problem. And then that we provide tax equity so that individuals who buy their own insurance have the same deductibility rights that currently only companies have. Those kinds of things, folding Medicaid into the larger program, tax equity, vouchers, community health center expansion, those things together can create not only universal access, but also redundancy in access. In addition, there are many of us who believe that we have to have a mandate to achieve universality, but that's an issue I'll come back to in a moment. Those are the kinds of things in access and in cost control that we all agree on. Those are the major actors. There are minor actors like the security card, administrative costs, anti-fraud provisions, antitrust provisions, but the big cost control initiatives are going to be insurance reform, collective purchasing, which sometimes are called HIPICs, malpractice reform, and then some kind of greater thrust like tax deductibility or global budgeting. But the big controversies that are out there and around which and on which this debate will focus are the following. And I would remind you, and I'm particularly conscious of this in the context of Hale's comments, there is so much that we can agree on, and so much that would have a profound and systemic impact on healthcare costs and on expansion of our delivery system and on the improving quality of care in America, that I personally am very hopeful and will focus hard on not letting these sort of big differences, these macro differences, prevent us in the end from passing health care reform. But the macro differences are significant. For example, the president believes that you can only get universality if you mandate health care as a responsibility of business. Those of us who oppose that, and most of us support the individual mandate with the voucher subsidy capability, those of us who oppose the business mandate do so for two reasons, and they're not well understood. The first one is well understood. We fear that by mandating costs on small business, the health care costs on small business, we will fulfill what every researcher has predicted, and that is we will slow the rate of growth of jobs in the small business sector. Now, that alone, one could probably dismiss. But you cannot dismiss the fact that the small business sector is the way up in America. More small businesses are being founded by women than by men these days because women have a harder time rising to CEO or top management. And so it is better for them to found their own business because it breaks the barriers that the current structure of our economy puts before them. The link between going into business for yourself and that underlying sense of opportunity in America, of economic freedom, is so great and so real that I certainly don't want to risk it on the hearth of health care reform when I believe access can be achieved through other means. But secondly, and actually almost more important, is the impact of the mandate on large businesses. This hasn't been talked about much because most large businesses provide health care. But the impact of the President's mandate is to change health care from a variable cost for a business to a fixed cost, to a percent of payroll, and furthermore, a percent of payroll established by the government. So if you do that, if you go that direction, you have the effect of eliminating all of the creative minds, all of the enormous energy that the private sector has put into the subject of cost control. That means all the wellness programs, all the investment that goes with them, all the things that have come from the private sector to control costs progressively and responsibly will no longer come from that sector, and there will be a massive shift of both responsibility and power from the private to the public sector in terms of who is going to have to meet the cost control challenge. And in that regard, I would just remind you that the government has met its cost control challenge in one of only two ways. In some programs, we fix prices within a global budget, and in other programs, we simply under-reimburse. That is, we fix prices not within a global budget, just within whatever the feds and the states believe they can afford. And in both instances, we have not even been willing to reimburse prevention, not to mention pilot things like wellness programs. So in sum, the government's record in cost control is not only not one of controlling costs effectively, but certainly not progressive. And in contrast, the private sector is doing a far better job in both progressive approaches and in effectiveness. The mandates is a big issue. I'm not going to go into the other issues in such detail because I think my time is expired. But the other issues turn on the level of government involvement and in the degree to which we reorganize purchasing and bear the administrative costs that are going to go with that reorganizing. The evidence shows that the small business market needs to be reorganized. The Republicans take away existing barriers and encourage collective purchasing. The bipartisan initiative, of which I am a part, restructures the small group market with a purchasing cooperative, which has some real advantages, both in terms of access and cost control. But the President's proposal reorganizes effectively all of purchasing. And one needs to question what will be the consequences of health alliances from the point of view of power and control. And on both of those issues, I assume we'll have a chance in the question period to get back to those kinds of issues in the Health Alliance. It's going to be an excellent debate because the members of Congress are better prepared for this complex debate than any debate that I've been a part of in my now almost 6 terms in Congress. Believe me, I believe that if members had been half as well prepared for the NAFTA debate, we wouldn't be having the debate we're going to have tomorrow night. Members have been paying attention on health care. They've been studying. They've been talking to their constituents. They've been studying their districts. And this is going to be a very rich, very important, and very promising debate for our nation.
Thank you, Nancy. Our final speaker is Steve Roberts, who, like his brother Mark, graduated from Harvard College. Instead of sticking around the campus, however, he went off to work for the New York Times as a research assistant and got his first job as a cub reporter for the Times during the first year of the Lindsay administration. He went on to become the Times bureau chief in Los Angeles and in Athens. He later was the chief congressional and chief White House correspondent for the New York Times and recently left to become senior editor of U.S. News and World Report. You may know Steve's face because he's a regular on Washington Week in Review. And on the side, he's an adjunct professor at George Washington University where he teaches a course in the role of the press in making public policy. Steve.
Well, I am really delighted to be here. I find increasingly I'm known in terms of my relatives, and in this gathering I'm certainly very pleased and proud to be Mark Roberts' brother. Mark and I, on our senior year in Elliott House, lived across the street, literally. Our senior room you can see from the front steps of this building. That means one of two things. Either Mark is a man of enormous focus and steadfastness and direction of purpose, or that he could never get another job. But in any case, it is nice to be back here with him. And of course, I do bring regards and regrets from my more famous spouse, Cokie Roberts. You know, being married to Cokie Roberts these days is a rather interesting process. Among other things, it means I'm among the 6% of American men whose wives make more money than they do. I kind of recommend it to you guys, actually. You know, I noticed the other day, Robert Blendon, your colleague, who's been, and you mentioned, Hale, that you're involved with the Kaiser Family Foundation. I was recently reading some of their most recent survey research, and it turns out that Americans actually trust Hillary Clinton more than they trust Bill Clinton on health care. Being married to Cokie, I kind of know how the president feels. I'm going to send him a membership card in the Dennis Thatcher Society. It's going to be a very interesting group of people. I'm going to talk a little bit about the politics of this subject, and then we can get to your questions. And I think in many ways the politics of this issue can be summed up by two numbers. The first number, and these are both taken from a poll that USA Today did some weeks ago on healthcare. The first question and the first number is, Americans were asked, do you believe the government should have a big role in healthcare reform? A big role. 55–60% said yes. Now that is a number you never would have seen in Washington or around the country during the Reagan years. Remember the watchword of the Reagan years: government is the problem, not the solution. I believe what's happened in America politically, and this is not just true for health care, but I think what's happened is we've seen something of a pendulum swing back from that apex of conservatism. Now that does not mean that Americans want to pay more taxes. It doesn't mean they want to fill out more government forms. It certainly doesn't mean they want more bureaucracy. But there is a growing sense that there are certain things in this country that even the most conservative, independent people cannot do for themselves. And a lot of this is really summed up in the president's recent discussions of the issue of security. The word that he has chosen to really define at least some of the goals of his domestic and even his international programs. I think it's a good word. I think it's an accurate word, and I think it does describe a lot of the yearnings that people have. Just a couple of examples. You can be the most conservative person in America, and you got a toxic waste dump in your backyard or in your town. You can't fix that yourself. You can't depend on the free market to clean up that toxic waste dump. You need government regulation and probably government aid to get that done. Or you take the issue of education, something near and dear to the hearts of anybody in this room. I'm often asked when I make political speeches and talk about politics, well, what the hell does middle class mean anyway? It's the buzzword of the year. I came up with an idea once that people seem to relate to, so I repeat it. Middle class is when you make too much money to qualify for any government help to send your kids to college, but not enough to be able to afford it out of your own paycheck. Now, as middle-class Americans look around and say, where do I need help in my life? Where are the moments of crisis and vulnerability and need where I think government has an appropriate role? Very few are more poignant and more important to many American families than the issue of helping to finance education. And health care fits in that pattern. Health care fits in that pattern. You can't see it in isolation. You can't see the politics of health care in isolation. You have to see it in terms of a pattern of attitudes toward government, I think. And I don't think there's probably anybody in this room who hasn't had the experience in one way or another of feeling in their personal lives the vulnerability of this healthcare system, and the vulnerability that this healthcare system can place people in. Now, maybe it's not in your own lives, but maybe it's in a brother-in-law's who's lost his job. Maybe it's in a child. I bet the percentage of kids who graduate from Harvard in June and who get jobs that involve full health care benefits is pretty damn small. My own daughter has spent the summer without health insurance while she's been between jobs. I said, for God's sake, don't drive. You know, but particularly given her driving record. But but I was recently at Cokie and I were recently speaking at a conference in Oregon. A woman drove us to the airport. She was talking about her own family and her own children. She said, as my 4 children have graduated from college, what I have given them as a present, each one, is a year's worth of health insurance. Now that's reflective of where a lot of families in this country are. And I think that experience, it's a question of experience, not a question of ideology. It's not a question of sitting around seminars in a building like this, as wonderful as it is. It's a question of experience that's driving that number, that part of the politics of this debate, which is a desire on the part of a majority of Americans to see government play a bigger role in helping to protect them from that vulnerability that the current system allows at different stages of different people's lives. But the other number that is the other defining pole of the politics of this debate, in the same survey, when people were asked, should government have a big role, and 55, 60% said yes. People were asked, do you think the government will do the job well? The answer, as you can already guess, was 18%. And those are the 2 numbers that are defining the debate. Now, why is it at 18% when the other number is at 55%? What helps explain that? It's very important to understand that because it's so critical to the politics of it. Well, I think there are 2 large reasons. One is simply we've been deluged for a generation with anti-government politics and propaganda. Ronald Reagan, of course, made a career of attacking the government. In fact, Ronald Reagan, as he was leaving Washington after 8 years, pretended as if he hadn't even been there. Of course, there were some people who thought, in fact, that was an accurate description of his presidency, but the truth is that he had made a political living on attacking the government. Of course, Ross Perot is his lineal descendant in that regard. But that political propaganda and that political arguments would not work as well as it does if, again, it didn't come back to experience. And that 18% figure is basically rooted not just in propaganda, but in experience. How many of you in this room have ever dealt with the government and come away feeling good about it? I mean, you know, that oldest joke in the book, you know, the 3 biggest lies are, you know, the check is in the mail, I'll respect you in the morning, and I'm here from the government, and I'm ready to help you. And the smirk that old chestnut of a joke elicits reflects exactly the problem that the administration, political problem, the administration is dealing with. I just recently had the experience I'm sure almost everybody in this room has had. I gave a speech one day at the National War College, Naval War College in Newport, Rhode Island, a very nice event, and I was glad to be invited. And they sent me a 12-page form to fill out in order to get my check. I would have to hire an accountant to fill out this form. And I was sitting there thinking, imagine if I did business with the government on a regular basis, which thank God I do not. So the experience of many Americans is not a happy one when it comes to the government. Now, that means this. When Bill Clinton says to you, when this administration says to you, as the American voting public, what we're really asking you to do is trust government again. What this administration is, and this is not just true in healthcare, but that's clearly the major event. They're asking you really to say, we're going to send more of your taxes to Washington, and we, the government, is going to spend this money wisely. We're going to spend it gently. We're going to spend it as if it were our own. And everybody in this room knows that that is a very tough sell politically, a very tough sell politically. Now, how is this going to come out? I think the debate in many ways will be a synthesis of these two poles: the desire for government intervention as a source of security and protection, and the very deep suspicion that government really cannot do this well. And to try to overcome this political problem, that's why you had, for instance, this fall, Bill Clinton talking about reinventing government, talking about reducing the White House staff by 25%, talking about all sorts of other kinds of administrative reforms and reducing paperwork and all that. Because he knows that you will not, you the American people, you as voters and consumers, will not trust government unless you are given some reason to have more confidence in the government. And that is, as I say, a very tough sell. Now, I would make a final point, and then we'll get to your question because I don't want to keep this going too long. In some ways, this tension between these two poles, these two political poles, can really be summed up in the attitude. Remember when, I guess it was the president, held up that card, that little plastic card, and said, "This is going to be your health security card." Now, if, in fact, Americans believe, as this debate goes forward, that that card is a sign of security, a source of security, in the same way that Social Security card is in your wallets, then I think he has a chance. I know you might be doubtful that Social Security is going to be there, but that's not true. It's going to be there. If only because politically it's impossible to not do it. But if that card, that symbol of the government, comes across as a symbol of security and reliability and protection in your moments of vulnerability, then I think the system's going to work. And I think that the Congress, as Nancy and others have discussed, will come through with a program that will meet generally with public approval. But, and I think the jury's out on this question so far, if that card becomes something else, if it becomes a symbol of government bureaucracy, in effect, if it's not your Social Security card, but it's like your driver's license, where every day at the Department of Motor Vehicles feels like a month, if it becomes a symbol of all the paperwork you have to do, if it becomes a symbol of all of the bureaucratic mess you have to go through, if it becomes a symbol of an increasingly complicated and inefficient delivery of health care services, then the public will reject these reforms. So that's how I think you have to see the politics, as playing out as an oscillation between these two impulses. And as a final word, never, ever, ever underestimate the ability of the American voting public to hold two contradictory views at the same time. So with that, thanks very much.
Thank you, Steve. I'm going to give Mark one last chance to respond, but before he responds, I want to announce that tonight we have 2 microphones on the first floor. People who want to ask questions should line up. You'll have to identify yourself and then state the question, but I wanted to give people on the second and third tiers a chance to get down to ask questions. Mark, and then we'll go to the questions.
One of the really difficult problems that citizens are going to have in the ongoing debate is to decide which of the many claims that are made are in fact true. It's going to be very easy to make claims about the likely impact of a given plan, particularly in view of the fact that actually doing something that will solve the problem of the healthcare system will not be easy. And so there's a great tendency for there to be snake oil salesmen abounding in the land. And with all due respect to Congresswoman Johnson, I think several pieces of the Republican position simply don't follow. And for example, it's not true that malpractice has a major cost impact. We've had a really excellent study done about this. Malpractice insurance rates are about 1%. The AMA thinks that the cost of malpractice is 3%, and they have a vested interest in coming up with a high number. And something she mentioned as a minor matter, administrative costs, that's a big number. The administrative costs within the hospitals, within the health insurance industries, are a much more important part of the issue than malpractice. But malpractice is such a nice thing, right? We can reform the malpractice system without affecting the structure of reimbursement, without hurting the insurance companies, without discommoding the doctors. And we can pretend and promise that we've done something significant. And really, malpractice reform is trivial. The really serious pieces of the mistakes in the system and the problems of the system are deep into the system, and we will not get big changes in performance with only small changes in the structure. And Hale can say all he wants, we have to worry about politics and not policy, and we have to compromise. But it's quite possible that if we do that, we will get something that won't work. And we are playing with the credibility of government, as Steve said. If we put in place a plan with a lot of high-sounding promises, and then healthcare costs continue to rise, and people discover that they don't really have security, what will that do to the politics of America in the next round? So I think literally, in some ways, the credibility of the Republic is at stake. And from that point of view, reforming the insurance market will do nothing to control healthcare costs. It may help middle-class people get somewhat better access. You do away with the exclusion for pre-existing conditions. You insist on community rating. You'll do something for middle-class access. But that will not do anything about controlling healthcare costs because in many ways, competitive vertically integrated providers will, in the short run, increase costs because everybody will want to be a full-cost provider and everybody will want to offer everything to everybody. We've had it here in Boston. We have the Mass General Hospital busy opening a new maternity unit and stealing 5 hotshot maternity physicians from the Brigham and Women's Hospital when the number of births in the town is going down, when we already have surplus capacity, when the New England Medical Center opened an unneeded maternity service just last year. And why are they doing that? Because of competition. It's not obvious that competitive forces will produce rational allocation of resources in the system. I think it's very important for you to think hard about how the real structure of the system will work. Not every claim that's made for every nostrum is necessarily justified.
Congresswoman Johnson, do you want to respond to that?
Yes, I'd love to respond. First of all, in his opening presentation, Mark, you neglected to recognize that one of the big differences between the cost of health care in Europe or Canada and the United States, and some would say that these things equal the differential, is the extraordinary rate of teen pregnancy in America and with it low birth rate babies, the far greater rate of violence and therefore emergency room care, the far higher level of substance abuse and of AIDS. And so if we don't change the system and make reforms in other areas, we still won't control health care costs. But to the specific issues that you addressed, no one ever claimed that the litigation costs or the premium costs of malpractice reform will make a big dent. But the AMA has suggested that that defensive medical costs could be anywhere from $37 billion to $70 billion, and very reputable studies have put the cost somewhere in between $20 and $70 billion in terms of savings. So it's very significant money, but more importantly, it goes to that level of deep systemic reform that health care reform has to reach, or it will not provide us with affordable care for all, because it will force not only physicians and other providers, but also patients to think in terms of what is really going to impact the quality of life. And this whole habit of doing whatever can be done cannot be addressed unless we relieve providers from being forced to do whatever might be done without regard to whether it is medically defensive or even humane. In addition, I certainly would want to say that insurance reform will help control costs. It is not the whole answer, but in the states that have tried it, in California particularly, it is the costs for the standard benefit plan in the small group market have gone down both within the purchasing cooperatives and outside the purchasing cooperatives, and each month 20% of their new enrollees are people who have never had insurance before. Now, it's not going to make insurance affordable or accessible to everyone, but it certainly is a part of the puzzle, a piece of the solution, and furthermore, it will have that other effect that I talked about, without which we cannot force the level of attention to prevention, the amount of use of outcomes research, that an affordable, high-quality, a universal access system demands.
Thank you. I think we'll go to the questions. Mark, looks like you'd like to respond, but I think we'll go to the questions. We'll start on the left, and again, just state your name and your question.
Sure. My name is Gail Price, and I'm a former student of Mark Roberts. Mark, I wanted to ask you, related to your comment about competition not reducing costs, how the health alliances and the Clinton plan can be expected to reduce costs at all. My understanding is that the theory is that their large buying power will force insurers and providers to kind of reduce their profits and to be more efficient, and I question their ability to do so. Second, it's commonly believed that prevention saves costs, but I've been told by a couple of health economists that preventive services don't always save costs, that it's very costly to change health-related behaviors like smoking, substance abuse, violence that were just mentioned, and that massive screenings oftentimes are very expensive for only finding one or two cases. So my concern is that perhaps these things may not save costs at all, and that the only alternative, or what may end up happening, is that there'll be so much pressure on insurers and providers to improve productivity that quality will be compromised.
I did not plant the question. On prevention, we have a lot of experience from the health maintenance organizations about what the incentives are on providers to do with regard to prevention. And what we know is, in fact, there are relatively few incentives on the part of providers to really provide prevention because, among other things, prevention produces savings in decreased healthcare costs in the long run. And people are so mobile and move around and switch providers so often that why should I invest today in improving your health status 10 years from now when the probability that you'll still be a member of my health plan 10 years from now is so low? And by and large, HMOs now do much less in the way of screening and prevention than they did when they started because they've learned that it doesn't really pay. So I really question whether or not a competitive system will do that. The second point, in fact, we know that I think it's a mistake to sell prevention entirely on saving money because I think the real goal of prevention, in fact, is to improve health status. It's clear that some preventative efforts will increase expenditures. It's possible that motorcycle helmets actually increase expenditures because what they do is produce a lot of live, seriously injured people who otherwise would have been dead and not burdened on the healthcare system. That may sound brutal, and I don't think that means we shouldn't have motorcycle helmets. I think we should have motorcycle helmets, but I don't think you can sell prevention simply as cost containment. I think the value of prevention should be as for health care because of the health benefits prevention produces. It's not just the cost benefits prevention produces. I don't understand. Honestly, I'm in a difficult position. I applaud the president's desire for universality. I applaud the desire for mandates. And so I'd like to be really enthusiastically in favor of the plan. But the question that Gail raises about the health insurance purchasing cooperatives is a very serious one. It's not clear to me why creating 100 new bureaucratic agencies will lower administrative costs. And it's not clear to me, and it's in fact, under the current plan, these co-ops are not going to shop. The co-ops are not going to be informed buyers because the co-ops are going to have to list and offer as options to individuals every qualified plan. So there's not going to be any room for the co-op to act as sort of an informed shopper in the president's plan. It's merely going to be a pass-through. And as Nancy said, and there's one thing I absolutely do agree with, The President's plan will end the private health insurance market as we know it and will turn it from a wholesale into a retail market, because all buying will then be done by individuals. There will no longer be a role for sort of corporate benefits officers to create special plans. And I think that's a serious objection. If you actually look at the numbers on low birth weight and violence, those are incredibly serious problems in certain parts of the population, and they're absolutely something we should work on. But they are not, in fact, important contributors to the overall costs of the system, because the overall costs of the system come not from the amount of care we provide for the poor, but from the amount of care we provide for the middle class.
Nancy, we can't see you. Hale and Steve want to get in on this question as well. Do you?
I have been cut off during some of the questioning, so I'll just speak up when I need to get in.
Okay. Hale?
Mine is, without going into detail, do not put too much trust in economics in this whole discussion. The economics of healthcare are not the economics of supply and demand and other such things as we know them. And the notion that you're going to somehow construct something that will make the economics come out right is not only untested, it probably has no reasonable base to begin with. And I think it's interesting that almost everybody who has any kind of position on any of this, in the end is relying, and this is where we come back to Steve's important question, on some major forms of regulation to make it come out right. What are the rules going to be? There isn't any system that we can do here. You know, the fact is that Clinton, I suppose, politically would have liked to say market competition, and many of the Republican plans sort of say, let the market take care of it. Everybody who's been through that really understands that the market won't take care of it. Clinton says, okay, well, he's now come down from global budgets to saying we're going to fix premiums, but I think probably those premium costs are based on some notion of a global budget of one kind or another, so it's a different way of doing the same thing. But you're saying we don't really trust this to hold down costs. And that really is the fact, that any plan that doesn't come back ultimately with some discipline in it that says health costs in this country, people keep talking about reductions. We're not talking about reductions here. We're talking about slowing the rate of growth. And it's happened twice in the last 50 years. Once it happened when Nixon briefly put price controls in and health got caught in it. And the second time was when Carter tried to get cost containment and the health industry got scared and they said, well, we'll do something voluntarily here. And as long as that bill was before the Congress, they did restrain costs. The minute that that bill was defeated, bingo, they went again. The fact is that you are going to require some government regulation, a government ceiling, a budgetary requirement of some kind, and whether or not the public will buy that is another question. But behind all of these conversations about how you do this or how you do that has got to rest a governmental determination arrived at in different plans in a variety of different ways that there is a ceiling.
But Hale, if I may I comment in?
Yes, come right in.
Yeah, if I may, you're absolutely right. There's going to be government policies that are going to impose constraints on costs. But there's an enormous difference between those policies proposed. For example, if you allow companies only to deduct, and individuals, the value of the average health care plan, then you're going to focus the competition at providing the benefit plan at the average cost. And so you're going to have a great variety of efforts at wellness, at involving people in their own recovery. You're going to have a rich development of the part of the solution that we know is the most important, and that is the reorganization of the delivery of care. Now, in contrast, instead of using tax deductibility to focus competition at the sort of efficient sector, if you use a global budget that caps premiums, and that's exactly what the president does, and he backs up those premiums with a formula in law that says that in the third year, then costs will be only CPI plus 1.5%. And at the end of the 5 years, medical costs will go up only inflation plus population, which is less than any other country in the whole world has ever achieved in
Well,
recent
plus
years.
also technology. There's several other factors.
No, you're missing my point. The law says that the formula for the budget that will govern the premiums will automatically ratchet down. So the premiums will have to ratchet down, and the private sector will have to respond. And the only way they would be able to respond in that time frame is to be very, very tough about access to care. That's just sort of the plain facts, and there's a lot of difference between ratcheting down premiums in the context of a national formula to control spending and focusing competition on the sort of mid-range of plan cost, because then when costs begin to eat into the bone of care, then you don't go any further in a voluntary competitive system. In the government system, you can easily be pressed into going well into the marrow, as both Medicaid and the VA system show, and the Medicare system is well on its way. So those of us who want to reform health care in a way that we think will work are very conscious of the experience the nation has had and the precedents that are out there. And I think not to discuss what a different model and how different our experience has been with global budgets controlling premiums and by dollar amounts denying care versus focusing competition in a healthy fashion, in an effective manner, would be really a real disservice in this debate. So I want to be sure that the examples of reality...
Well, I don't want to argue the whole question, but I do want to make a language point here for the rest of this discussion. We are not talking about ratcheting down. We are not talking about cutting. We're trying to slow the rate of ratcheting up. 10, 15, 20% a year.
Well, we are certainly trying to do that, but you see, the President's plan, by going to zero real growth, does try to do something that not only no other plan has done, but even the
Nancy, it's
government...
not true that the German percentage of expenditure on healthcare costs is actually going down as a percentage of gross domestic product.
But it's still well above inflation.
No, it's not. And I would point out to you that Hale and I arguing a global budget, we're the Republicans here. I mean, it's always been the Republicans who backed the change in congressional process that required the omnibus budget reconciliation process. It's Republicans who said that unless you wrap a limit around expenditures will tend to grow without limit. And we're just espousing plain old-fashioned Republican fiscal conservatism here.
And what I'm pointing out to you is that there's a difference between mechanisms. If you focus competition on tax deductibility at the center of the scale, you're going to get real competition, but also a limit set by government policy. But if you just do it through global budgets and that kind of mechanism, which I would disagree with you that Republicans have supported that so much in other areas, but at any rate, there's an arbitrariness in the present system that is going to be very destructive, sitting on the Ways and Means Committee that actually does try to cut the rise in Medicare costs every single year using these exact tools. I can tell you, I have no idea how the president thinks he's going to cut Medicare as much as he says he's going to. And when we ask that question at hearings, what new strategies are you going to employ? We get the answer that we're going to cut costs systemically. So I'd be very wary about means and ends.
I'll just add a very quick word about preventive medicine. I happen to be talking to Senator Mitchell about the subject at lunch, and he says whether your economic analysis proves him right or not, that preventive medicine, I think very wisely, will be an important part of any incentives they try to build into the system. But as Hale's point about the interaction of politics and policy, it's a very good example, because you have, for instance, heavy taxation on cigarettes because there are relatively few states that grow tobacco, and they can probably be rolled in the process. But you try to tax something like alcohol, and you've got a much bigger political problem, even though you can still make the case that from a rational point of view this would be a good thing to lower substance abuse, to say nothing, of course, of taxing ammunition, which was a proposal that Senator Moynihan brought out the other day, and one that from any rational point of view in terms of trying of preventive medicine that has policy implications, but politically it's not going to happen. So it's just that it's a good example of how you really have to talk about the two at the same time.
Next question.
Well, I really just came to get Koki's autograph, but since
There's a long line. Now you
Okay.
you can.
okay, my name is Al Nava. I'm from Los Angeles. One of the things that I've noticed in the national debate is probably the missing link of people of color having some input. One of the biggest problems we're finding for the minority or now the majority, like in Los Angeles, is that there are medical differences in practice by local communities that medical practice today, modern practice, cannot meet. And I haven't heard anything in this plan directed towards the issue of people of color.
One of the things that we know from the data is that actual access to care by people of color is much lower than in the majority community. And it's in part a function of the financing system, and it's in part a function of the sociology. And one of the things that I think we have to be very concerned with in any community-rated system in which the insurance premiums for everybody are the same, that leads to the possibility that it will become particularly attractive for an insurance company, as I said, to discriminate against high-cost individuals. And given the degree of social problems in the minority community, the fact is that there is a correlation between low income and ill health. And there is a correlation between ill health and being a person of color. And so we're going to have a very serious problem about guaranteeing access in a competitive system. And this goes to Hale's point about regulation and competition. If you listen to some of the competitive advocates, they argue that competition is an alternative to regulation. What's actually going to happen in healthcare is that the increase in competition will produce an increase in the need for regulation at the same time, because so much of the competition will be perverse, as in people competing by, seeking to make profits by, denying access to communities of color, because that will be the profit maximizing strategy. So then we're going to have to get into regulating where people open offices, or we're going to have to get into a complicated system of interplan risk adjustment transfers to take accounts of these things. But a lot of the competitive forces are going to be perverse. Indeed, even within a plan, one of the most successful plans in Southern California now pays primary care physicians a bonus to make sure the individuals who they treat don't get care. And I think this is, from the point of view of a potential patient, this is somewhat troublesome to think. I mean, it's bad enough that your physician is paid more and tends to do too much to you, but I'm not sure that isn't better than having your physician paid more to do even less to you.
I might add that a lot of what the reason you haven't heard, I think, a lot of major public debate about this is it's pretty well understood, and certainly with the congressional representation involved, going way back into the development of the Carter Plan, that a lot of these issues are being dealt with, and they're not therefore big divisive issues. I think the Congress will take care of that in its own way. Charlie Rangel was one of the prime authors of looking at this set of concerns. The other thing is that a lot of the drive for universal is going to produce the opportunity and the character of a system where you can get some attention to special population problems. You need to be careful in terms of the cost controls that you don't drive it out, that you recognize it as a special concern. But there are a number of those special concerns, and I think they're pretty well addressed in most people's plans. The Congress won't pass anything that doesn't really address that set of problems.
My name is Eugene Donner. I'm a graduate student at the School of Public Health here at Harvard. What would you encourage states to do legislatively to prepare for national health reform? In particular, I'm interested in rural states.
Are you addressing that? Well, I think it's perfectly clear that some rural states are not going to have the capacity initially for managed care on a competitive basis. They're lucky enough to get the care, one system of care, and that some of those states may very well therefore go, and that's one of the reasons that I say let people do this thing their own way to some extent within some macro policy. Because it just doesn't make any sense to expect that the kind of competition that you would get in Minnesota or Rochester or Boston is going to be there in some of those rural states. Anybody who's ever been 40 miles south of San Antonio knows there's not a doctor in that territory.
I think states need to be very involved right now in surveying their own infrastructure. Where in their state are there no obstetricians? Is there no triage care? What is the reuse that's being planned for small rural hospitals that can't survive under today's Medicare reimbursement rates? Once you identify those problems, there is federal money available to convert small rural hospitals into clinics and emergency centers. States ought to be prepared to know exactly what kind of airlifting capability they're going to need to hook small rural health centers with more sophisticated treatment centers. They ought to be looking at what kind of imaging technology they're going to need so that those small centers can have on-site consultation from the big medical center in their state so that emergencies can be dealt with as if the specialist was right in the room. No, that's the kind of investment in technology that we're going to have to make to assure that rural communities have access to the quality of care they need and the triage transportation capability that is so essential to preventing an accident from becoming lethal or creating lifelong handicap.
In small states, service integration, letting health work across with social welfare and other concerns is part of this business.
Yes.
My single sentence of advice is go right ahead just as fast as you can in your own state, doing what you want, proposing waivers, and hope that something else is coming, but don't wait for it.
We have time for 2 short questions.
My name is Herman Suda, and I would like to address a question to Mr. Mark Roberts. This deals with the impact of new technologies and the cost of health care. And I noted your less than enthusiastic description of young scientists in the medical school here and their efforts to bring new things on which perhaps would contribute to more expensive but maybe more effective medicine. The tenor of your comments, sir, seemed to me to be one that we'd be better off if we were to stop new technology development. And I'd like for you to comment on that.
Thank you for the question, because it's not the impression I intended to leave, but what I would like to do is redirect technology. I think that the interesting question is not whether you're pro-technology or anti-technology, but what kinds of technology would you like to provide incentives for? And I think it is not sensible to have an incentive system in which there's great rewards, financial and academic prestige, in academic prestige terms, for developing extraordinarily expensive techniques that only add very marginally to the performance of the system. I think it would be really wonderful if we could encourage people to think very hard about new ways to deliver care in much less expensive ways. And if we directed our technological change at cost-saving innovation as opposed to performance-enhancing innovation. I'll give you a specific example. Since the time when HIV was widely transmitted to hemophiliacs through HIV-infected blood, we've developed columnar filtering techniques for blood that have reduced the transmission of HIV in patients receiving factor VIII clotting factor essentially to 0. Biotechnology has recently developed a new technique for producing factor VIII through recombinant DNA engineering out of bacteria with no human blood involved. The existing filtering techniques has produced no known case of transmission in the last 5 years. The new recombinant technique costs as much as $100,000 per patient per year more than the existing technique. and there's going to be great pressure to use it. Now, I think that's what I call flat of the curve medicine. We're spending a great deal of money for not very much more, and I'd like to put all those smart people to work finding out ways to bring costs down instead of drive costs up.
And that, and I think that has to be seen in terms of another question, and the dreaded R word, which has not been spoken yet this evening, which is rationing. When you talk about the politics of healthcare, and you talk about everybody's been talking about cost containment and cost control, but in fact, inevitably, it seems to me, inevitably, that any sort of effective cost containment is going to have to involve limitation of certain services to certain people at certain times in their life. As Mark said so well, you know, we treat death as an option, so all the figures show that so much of the costs are expended on the last few months of life, often with very little marginal return. And so I think that you can't divorce what Mark's talking about in terms of trying to find more cost-effective uses of technology from the political and economic realities of the side of the equation, which is any sort of cost control regime is going to force upon the medical system choices which no one wants to talk about. But they're going to have to talk about.
Look, we make those choices now. The question is not whether we have rationing, but how we ration. If by rationing you mean not everybody is going to get everything that they would want to have if they confronted zero prices. That is, we're not going to give away medical care for free endlessly to everybody. We're going to pull back from that rate of expenditure. Then we already have rationing. Indeed, the earlier question about communities of color highlights some of the places where we have rationing. Particularly, we don't have effective access to outpatient care in poor communities, and that's one reason why those communities make much higher use of inpatient care, because they particularly use inpatient care for those conditions which, if they'd had decent outpatient care, they wouldn't have gone to the hospital in the first place. So we already have rationing by price, we already have rationing by income, we already have rationing by geographic location. The question is not whether we have rationing, but really what the priority setting mechanism will be.
And apparently you can talk about it, because they did in Oregon. They went through a big, long discussion of it and really reached some conclusions.
Hi, I'm Matt Taylor. The speakers in this lecture series have been remarkably consistent. Democrat or Republican, both seem to be committed to controlling the lives of other people. And if anyone thinks that Ronald Reagan really dislikes government, has never met a libertarian. In case anyone hasn't realized, healthcare today is more controlled by government than it is free. It's against the law for me as an adult to go to Kmart to purchase healthcare. It's not a misdemeanor, it's a felony. And I wonder if anyone would address the solution that hasn't been even proposed yet, and that is to decriminalize self-medicine.
As far as I'm concerned, you want to buy, you know, a brain surgery from Kmart, go ahead. I mean,
it's against the law.
I think you'll get what you pay for.
No, you know, if somebody wants to be a conscientious objector about health, there's no problem about that, but that doesn't free people of the responsibility of being citizens.
And one of the interesting questions is...
You can opt out if you want, but you're going to have to help pay for those who don't.
Well, one of the other interesting questions, which we haven't mentioned, but that is, the fact is we do have a system of financing care even for the uninsured, and it's through a variety of cross-subsidies for bad debt and free care. And one of the things that strikes me is we need to talk, and when we talk about people who want to opt out or people from the small business market who want to opt out, the fact is the majority of small businesses now do provide health insurance for their workers, and it's the people who provide no health insurance who are being cross-subsidized by the rest of us. Because the fact of the matter is that when someone with health insurance winds up in an automobile accident and comes into the emergency room, we don't now say, whoops, you don't have any health insurance, we won't take care of you. We have enormous cross-subsidies of the uninsured. And that's why I personally think that a mandate is not a terrible thing. Why? I mean, yes, we deprive the uninsured of their freedom to continue to be uninsured. But we also deprive people who steal of their freedom to continue to steal. The uninsured are basically taking resources from the rest of us by putting themselves in a position of vulnerability and forcing us to cross-subsidize them. And I don't see why limiting their freedom in that way is such a terrible limitation.
As a matter of fact, people who get health care at Kmart are probably going to end up in an emergency ward.
And that we're all going to pay for it.
And we're all going to take care of it.
They would end up in prison.
Yeah, I think the issue is, though, not how do we free people from responsibility, but do we focus the responsibility on the individual, or do we focus it on the small business? By focusing it on the small business, the society pays a price that I think is unwise, because it makes it harder for people to open their own small business, to expand their own small business. And the big difference between the way America recovers from recession and other Western industrialized nations recover is in the vitality and expandability of our small business sector. You look at the reports coming out of Europe now, one of the reasons they're having such difficulty is because their small business sector has been basically a zero job creator for a decade because of the heavy mandates on that sector. So it's not a question of whether there should be a mandate. The question is, do you put it on the individual, and does government, as a matter of public policy, tax to assure vouchers that guarantee affordability, or do you impose it on the small business sector and therefore impose those costs out of the public view, even though the purpose is for a desirable, I think, and justified public policy reason?
Nancy,
I think democracy needs to be up front.
if you'll support a tax increase for the purposes of funding individual mandates and vouchers, I'll go right with you.
I certainly will.
And on that note of agreement, we'd like to thank our panel, Mark Roberts, Hale Champion, Nancy Johnson, and Steve Roberts. Particular thanks to Nancy, who had to stay in Washington to vote and phoned in. Stay tuned for the next forum.
I was once in your home long ago when I